Hello everyone, I'm Dr. Prateek Joshi. Today we have a case of a young individual who has sustained twisting injury to his right knee joint. On MRI, he was found to be having complete ACL tear. With that, he also had a medial and lateral meniscus posterior horn tear. So on diagnostic arthroscopy, you can see that there is complete ACL tear. And as we go in the medial compartment, now we are going to see the displaced undersurface medial meniscus posterior horn tear. So as you can see, I am putting my probe in the undersurface of the medial meniscus posterior horn, and the meniscus is getting displaced inside the joint, which means it's a unstable tear. So we are going to repair it with one all inside suture. So I've inserted my all inside device first through the substance of the medial meniscus posterior horn, and then I'm going to deploy my first implant, and I'm going to withdraw the device, after which I'm going to insert the device inferior to the first stitch that we have taken through the capsule. And once I have deployed my second implant, I'm going to tighten the knot by pulling the thread, which is going to reduce the undersurface tear of the posterior horn of the medial meniscus. So now I've inserted the knot cutter. I'm going to cut the thread flush to the knot, and this is going to complete our first stitch. So you can see that now the meniscus is stable and it's well reduced. I'm just going to trim the margin of the posterior horn of the medial meniscus with the help of arthroscopic punch. So in the end, I'm going to use arthroscopic shaver to take out all the loose debris, and this is going to complete our medial meniscus posterior horn all inside repair. Now we are in the lateral compartment, and as you can see, there is a longitudinal tear in the white zone of the posterior horn and the body of the lateral meniscus. Since this region doesn't have good vascularity, this is not going to heal if we repair. So we are going to trim this central portion of the tear, and I'm using the arthroscopic punch to take out this tear, which is in the white zone, which is avascular zone with no healing potential. Now I'm going to use arthroscopic shaver to take out all the loose debris. So this is the picture after having removed the tear in the white zone, which was a longitudinal tear. Now there is another tear pattern which is visible, which is horizontal in nature, involving the red, white and red zone. So this zone has good healing potential. So we are going to repair this with the help of all inside sutures. So you can see I am reassessing the tear with the help of arthroscopic probe. You can clearly see there is a horizontal tear involving the posterior horn and the body of the lateral meniscus. So I introduced my first device from the anteromedial portal, and I have pierced the capsule superior to the meniscus, and then I have deployed my device and I am going to insert my device inferior to the meniscus, which is going to complete the vertical mattress configuration stitch, and this is going to reduce the anteriormost portion of the tear of the lateral meniscus. So this completes the first stitch, and now we are going to have another stitch slightly posterior to the first stitch. And as you can see, I've inserted my all inside device from the superior aspect of the lateral meniscus posterior horn. I am going to pierce the substance of the meniscus and going to deploy the first implant, and then I am going to withdraw my device, and then I'm going to deploy my second implant inferior to the lateral meniscus posterior horn. Again, I am going to cut the thread, and this is going to complete our lateral meniscus posterior horn and the body tear. And now the meniscus is very stable, it is well reduced, and is going to give good result in this patient. I am not going to put another stitch more posteriorly because it endangers the neurovascular structure just posterior to the capsule. So we don't want to have any neurovascular injury. So this is enough for this patient. I am going to just use arthroscopic punch to trim the posterior horn of the lateral meniscus, just the anterior-most portion, which is going to complete the meniscus repair procedure. So now we are done with the meniscus repair, and now we are going to start ACL reconstruction procedure. So as you can see, I have inserted my 6 mm offset femoral hammer through the anteromedial portal, and I am drilling my guide wire through the lateral femoral condyle in the ACL footprint. The guide wire is drilled, and now I am going to drill with endoverton drill bit over the guide wire to create tunnel in the lateral femoral condyle. The length of our tunnel is 38 mm. We are going to drill with 9 mm drill bit over the guide wire since the diameter of our graft at the femoral end is 9 mm. I am going to drill up to mark of 30 mm so that we can use 20 mm continuous loop endoverton and flip over the lateral cortex. Now we are done with the femoral tunnel, and you can see the tunnel is anatomical and it's perfect in its location. There is no blowout. It is in the ACL footprint. Now we are going to use the ACL tibial jig to drill the guide wire in the tibia, and you can see that the guide wire has exited in its anatomical location. The diameter of our graft at the tibial end is 9 mm. Now we are going to drill with 9 mm drill bit over the guide wire in the tibia to complete the creation of the tibial tunnel. So we are done with the tibial tunnel preparation, and you can see that the tunnel is in its anatomical location. We are going to use the shaver to debride the loose ACL debris around the tunnel, and it's important to do this to prevent cyclops lesion in future. In this we are using suspensory fixation on both sides, so we have just harvested only semitendinosus and we have created a graft which is 7 cm in its length and 9 mm in its diameter at both femoral and tibial ends. So we have preserved gracilis also in this case. Now I have passed my endo button attached to the graft through the tibial tunnel, and we are going through the femoral tunnel. And once we reach the mark, we are going to flip the button over the outer cortex of the lateral femoral condyle. And once the button is flipped, we are going to fix the graft at the tibial end with the help of a suspensory fixation using the peak button which sits on the outer cortex of the tibial tunnel. This is the video showing the fixation at the tibial end with the peak button, which is slid inside with the help of a sliding knot, and once it's sitting flush to the outer cortex of the tibia, that is the end point, and then we are going to tie the sutures on the peak button. We also have internal brace in this, which again we are going to tie over the peak button. So this is the final picture of the ACL. You can see the ACL is in its anatomical location. It's quite strong, and it is going to provide good stability to this patient in future. We are going to follow the ACL with meniscus repair protocol in this patient. You can see the graft is quite strong, and in this patient who is young and who is going to do sports activity in future, this graft is going to provide good stability. So thanks for watching this video. Do like and share the video. Thank you.